Patient, Ms. Elena Torres, 58-year-old female. History. Stage 4 hormone receptor positive breast cancer, bone metastases. Current treatment, palbociclib plus letrozole. Osteoporosis, hypertension. Medications, denosumab, lisinopril, calcium/vitamin D supplements. Presentation. Brought to ed by daughter, mom's confused, vomiting, and too weak to stand for 2 days. Vitals, BP 78 50 seconds, HR 118, RR 28, temp 37.1 degrees Celsius, SpO2 92% Ra. Physical exam. Neuro, GCS 13, E3V4M6, disoriented, absent DTRs. Cardiac, weak pulses, prolonged QT on telemetry. Renal, oliguria, 30 ml/HR, no edema. GI, abdominal distension, hypoactive bowel sounds. Labs, stat. Corrected Ca superscript 2, 15.8 mg/dl, albumin 2.2 g/dl. Creatinine, 2.6 mg/dl, baseline 0.8. K, 3.1 milliequivalent/L, mg superscript 2, 1.5 mg/dl. ECG, shortened QT, flattened T waves. Diagnosis, malignancy-induced hypercalcemic crisis with acute kidney injury. Immediate nursing priority for Ms. Torres. A. Administer IV zoledronic acid. B. Initiate 0.9% NaCl at 300 ml/HR. C. Obtain CT abdomen. D. Give K-oxalate. Answer, B. Severe hypotension/dehydration requires fluid resuscitation before bisphosphonates. Which symptom is most specific to hypercalcemia? A. Tachycardia. B. Absent deep tendon reflexes. C. Hypoactive bowel sounds. D. Oliguria. Answer, B. Hyporeflexia signals neuromuscular impairment from hypercalcemia. The corrected calcium formula used for this patient is, A. Take the measured calcium level, then add 0.8 times the patient's albumin level. B. Take the measured calcium level, then add 0.8 times the result of subtracting the patient's albumin level from 4.0. C. Take the measured calcium level, then multiply the patient's albumin level. D. Take the measured calcium level, then subtract 0.8 times the patient's albumin level. Answer, B. Corrects for low albumin, with a calcium of 15.8 and a low albumin of 2.2, it would be 15.8 plus 0.8 times the difference between 4.0 and 2.2, which equals 16.24 milligrams per deciliter. The provider orders zoledronic acid 4 mg IV pre-infusion action. A. Hold antihypertensives. B. Verify CrCl greater than 60 ml/min. C. Administer IV potassium. D. Start cardiac monitoring. Answer, B. Bisphosphonates cause renal toxicity. CrCl 60 ml/min requires dose reduction. During hydration, urine output remains 30 ml/HR. Next step. A. Double IV fluid rate. B. Add IV furosemide 20 to 40 mg. C. Switch to D5W. D. Administer IV insulin. Answer, B. The correct next step is to add intravenous furosemide at a dose of 20 to 40 mg. This loop diuretic enhances calcium excretion by acting on the kidneys, but it should only be used after the patient has been adequately rehydrated with intravenous fluids. ECG shows shortened QT interval. Pathophysiology explanation. A. Indicates hypokalemia. B. Hypercalcemia accelerates cardiac repolarization. C. Signals digitalis toxicity. D. Suggests myocardial ischemia. Answer, B. Hypercalcemia shortens QT by accelerating ventricular repolarization. Which medication is contraindicated? A. Hydrochlorothiazide. B. Furosemide. C. Lisinopril. D. Ondansetron. Answer: A. Thiazides reduce calcium excretion. Rightward arrow worsen HCM. Ms. Vance develops jaw pain 2 weeks later. Suspect: A. Oral mucositis. B. Osteonecrosis. C. Trigeminal neuralgia. D. Dehydration. Answer: B. Osteonecrosis of jaw, ONJ, is a bisphosphonate/denosumab complication requiring immediate dental eval. Goal calcium correction speed: A. 0.5 mg/dl per hour. B. 1-2 mg/dl per 24 hours. C. Normalize within 2 hours. D. 4 mg/dl per 6 hours. Answer: B. Rapid correction risks arrhythmia/rebound hypocalcemia. Post-treatment, Ca superscript 2 drops to 8.2 mg/dl. Priority assessment: A. Gvosdeck/Trousseau's signs. B. Skin turgor. C. Bowel sounds. D. Capillary refill. Answer: A. Tests for hypocalcemia, overcorrection risk. Discharge teaching priority: A. Drink 3 L milk daily. B. Discontinue calcium supplements. C. Increase cheese intake. D. Take vitamin D 5000 IU. Answer: B. Supplements worsen hypercalcemia, vitamin D restriction also critical. Which cancer carries highest HCM risk? A. Prostate cancer. B. Metastatic breast cancer. C. Chronic lymphocytic leukemia. D. Glioblastoma. Answer: B. Breast cancer causes 50% of HCM cases. Prostate rarely does despite bone mets. Pathophysiology teaching point: A. Tumor destroys kidney tubules. B. Cancer cells break down bone, flooding blood with calcium. C. Chemotherapy blocks calcium excretion. D. Radiation increases vitamin D. Answer: B. Osteolytic metastases. Rightward arrow bone resorption. Rightward arrow Ca superscript 2 release. Nurse notes new confusion post-treatment. Action: A. Administer haloperidol. B. Recheck calcium stat. C. Obtain head CT. D. Restrict fluids. Answer: B. Rebound hypercalcemia common, reassess before imaging. Symptom requiring immediate dialysis: A. Ca superscript 2 13.2 mg/dl. B. K 5.0 milliequivalent/L. C. Ca superscript 2 17.0 mg/dl plus anuria. D. Na 130 milliequivalent/L. Answer: C. Dialysis indicated for severe HCM with renal failure unresponsive to fluids. Mnemonic for symptoms: crushed, confusion, renal failure, urinary frequency, skeletal pain, hypertension, exhaustion, dehydration.
Critical safety alerts for HCM. Number 1 trigger: breast cancer bone mets, 50% of cases. Deadly triad: Ca superscript 2 greater than 14 plus creatinine greater than 2.5 plus GCS less than 13 equals 80% mortality at 1 year. Confusion plus constipation plus polyuria equals calcium crisis. In HCM, lethargy isn't just cancer fatigue, it's neurotoxicity. Nurses save lives by catching Ca superscript 2 spikes before cardiac arrest. Risk: action: Ca superscript 2 greater than 14 milligrams per deciliter. ICU transfer plus dialysis consult. QTc less than 300 milliseconds. Correct electrolyte stat: CR greater than 2.5 milligrams per deciliter. Reduce bisphosphonate dose. Jaw pain. Stop denosumab dental consult.
Hypercalcemia crisis safety. Red flags equals ICU transfer. CA superscript 2 greater than 14 mg/dl plus altered mental status. QTC 300 milliseconds on ECG. Creatinine greater than 2.5 mg/dl. Critical interventions. Hydrate first, NS bolus rightward arrow 200 to 500 ml/hr. Bisphosphonate second, zoledronic acid after euvolemia. Monitor electrolytes, K/mg superscript 2 replacement prevents arrhythmias. Discontinue offenders, calcium supplements, thiazides, vitamin D. HCM emergency mnemonic, calcium crash. Cardiac monitoring, QT prolongation. Aggressive hydration, NS 300 ml/hr. Loop diuretic after hydration. Correct K/mg superscript 2. Inhibit bone resorption, zoledronic acid/denosumab. Urine output goal greater than 100 ml/hr. Mental status checks hourly. Calcium supplements stopped. Renal protection, avoid nephrotoxins. Assess for fractures. Seizure precautions. Hospice referral if advanced disease.